So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never want to see another B unless I'm Jay-Z. Farm so hard, let's get
What's
paid.
good, fam? It's your host, Jim Pruitt, a.k.a. PharmD, the ED, and I'm bringing you another episode of the Farm So Hard podcast. I'm super excited to jump this episode off because we've been doing a ton of stuff out there in the community with the SCMP, with the EmpowerX conference, and I'm back in the podcast mode, and I'm ready to really, really get after it for the rest of the year. But enough about me, enough about the society. We got some really, really cool stuff on, and I'm back with an episode that's going to really make your next heart failure shift super smooth. And I have with me the boss of all bosses when it comes to cardiology. Again, she's going to be a clinical cardiology specialist at St. Joseph University Medical Center. She's the creator of CardioRx Explained. Won every award you can possibly think of, Pharmacist of the Year, Best Presentation Award. She's known for her visual analogies and memes. She builds all the protocols at St. Joseph. And again, she wrote an actual chapter on acute decompensative heart failure this last year. And she's a clinical assistant professor at Rutgers University. Guys, welcome to the show, Cait Kulig. Thank you for coming on.
Thanks so much for having me. That was a super generous intro, so thanks.
Perfect. So we like to jump right into these episodes and just give people a little bit of a background when it comes to you. Can you just give us a brief journey into heart failure as a specialty? Because people usually have a pretty good way to get into it.
Yeah. So I was born and raised in Jersey. I went to pharmacy school at UNC in Chapel Hill. I did my PGY1 and PGY2 at UC Davis Medical Center out in California. And then from there, I went right to my position now. So over at St. Joe's, I'm the cardiology pharmacist, both inpatient. So most of my days I'm going to be inpatient. I'm dealing with all types of patients from, intensive care patients to floor status. But then one day a week, I do cardiology outpatient clinic. So I also see stable heart failure patients. And then, over on the academia side, I also coordinate and teach the cardiology class there. So heart failure is definitely one of my favorite things in cardiology. So I'm really, really excited to be here today. So thanks.
This is going to be really cool because, again, I feel like when you get so deep into a topic and then you get to be academia on top of that, you really get into the nitty bitty of all of this. So I just want to get us going. Let's start at the very beginning of all of this. We throw around the term heart failure all the time, but for someone who's listening who just heard CHF on a sign out, what is heart failure fundamentally?
Yeah, that's a good question because, we'll be talking about this, but heart failure, the different hearts in heart failure can look completely different. The etiologies can be completely different. But at the end of the day, really what heart failure means is the heart is really unable to supply blood to the body effectively. So like I said, there are a ton of different ways that the heart structure and function can kind of look like. But at the end of the day, the heart just can't get enough blood out.
Perfect. And I know we have some really cool analogies when it comes to this. And I want to kind of shift to some terms that when I was looking at your notes, I was like, I'm going to be honest. I didn't know this term existed. So since I know I didn't know that, I'm pretty sure some of our listeners, can we talk about, HF-Ref and HF-Pef in the ED, but even going through the guidelines now, they have four official categories. Let's really nail down the systolic first, and then just go into some of the others, because I know you have a good analogy that we try to get into.
Yeah, it's funny you say that because I have an intensivist friend who's always making fun of cardiology, and she's like, you guys with your alphabet soup, your HF-Pef, HF-Ref, whatever it is. But just like you said, there are now 4 different categories in the latest rendition of the guidelines. So we still have our, famous HF-Ref and HF-Pef that we all kind of learned in school, which is our systolic and diastolic heart failure. So let's start with those. So systolic heart failure, or HF-Ref, is really an issue with contraction and squeeze. So I always tell my learners, think systolic, think S for squeeze. So in this scenario, your heart muscle is either dead or damaged, and so the myocyte cannot squeeze as hard. So because of that, you have less blood leaving the left ventricle because, the heart muscle is actually really dampered down and unable to have that good squeeze. So these patients have a left ventricular ejection fraction of less than or equal to 40%. Then we have our diastolic heart failure or HF-PEF. Just like when we're talking about diastole, this is going to be an issue with relaxation. So oftentimes in these patients, the space in the left ventricle where that blood can actually sit is very, very small because the heart muscle has hypertrophy. So I always say to my learners, keep in mind that your heart is a muscle just like any other muscle. So if I went to the gym, if I lifted weights with my biceps, which clearly I don't, but let's just imagine here, my biceps, right, over time, they would grow and they would get bigger and I'd be really swole. Well, your heart's the same way. So if your heart has to face high afterloads and push blood harder, like let's say you have chronic hypertension or whatever it may be, if it has to work harder over a long period of time, it's going to grow too. And as that left ventricle grows thicker and thicker and thicker, that space within the left ventricle gets smaller and smaller and smaller. So in diastolic heart failure, it's really a problem with volume and how much this left ventricle can actually hold. So when we're thinking about systolic versus diastolic heart failure, there's this really good analogy that I did not make up, but I think it's great. It's kind of thinking about a water bottle and squeezing a water bottle, right? So in a healthy heart, you have plenty of water in that bottle and you have good squeeze. So your end result is plenty of water coming out of that bottle. In systolic heart failure, you have enough water in that bottle, but you have poor squeeze. So your end result is still not enough water coming out. And then diastolic heart failure, you have good squeeze, but you start off with not enough water in that bottle. So again, end result is still going to be the same where you don't have enough blood leaving that heart. Now moving on to our alphabet soup, as my friend would call it. We have 2 new official categories from the guidelines. So it's going to be HF-Imp EF or HF-Ref or HF-Mr. EF. I think the correct pronunciation is still kind of in the air here. HF-Imp EF is heart failure with improved ejection fraction. So these are going to be patients who had a previous ejection fraction of less than or equal to 40%. So in other words, these were patients who previously had systolic heart failure. And since then, they actually had improvement of their ejection fraction. So this is really exciting for, because for the longest time in these patients that improve, we didn't really know what to do with them. Do we continue GDMT or do we stop it? So now we have some more information about that in the guidelines. And then lastly, we have HF-Mr. F or HF-Ref, and that's going to be heart failure with mildly reduced ejection fraction. So in the guidelines, the latest rendition, they basically broke up HF-PEF. So it used to be, greater than 40 on, and now it's kind of this in-between zone from ejection fraction of 41 to 49%. It's going to be mildly reduced. And then, everything above 49%, so you're 50 on, is your HF-PEF.
Okay. Perfect. And I think that's where a lot of times in the past, I remember when I was in school and I was like, this patient has it's 42. Is it low enough to kind of fit for that range, or are we going to classify him as? Or again, I remember always hearing people, it's like, oh, I had an EF of 15 and now it's 42. I'm like, so what do we want to do? Now we have Mr. and Imp to help us out when it comes to all of that. So
exactly. So I swear they have a purpose.
So just to add on to all the other letters that we have in the world. But I think sometimes we can get a little too ahead of ourselves and we think we know what ejection fraction is in a sense. I want to pause because everyone's saying my EF is 35, like it's common sense, but kind of walk me through again, what is EF in a sense? Because we've always talked about it and we give these estimates, but kind of walk me through what that means.
Yeah, I think it's a good question. And I think learners can kind of understand what that is until we talk about diastolic heart failure. And, what does that mean? I have a preserved EF. Do I have, heart failure? So ejection fraction is kind of what the name sounds like. It's going to be a fraction. So it's going to be one number over another number. So I always like to go old school, like Magic School Bus, Mrs. Frizzle. I like to pretend like I'm in the left ventricle, right? So blood is already oxygenated at this point. The next step is really that blood leaves the left ventricle and goes out to the heart, into the body. So right before your heart contracts, so at the very end of diastole, we call that end diastolic volume, right? And that's going to be when your heart is at its fullest. The other term that we're talking about here is stroke volume. So for you guys who may not remember, stroke volume is the amount of blood that the left ventricle will spit out in one contraction. So ejection fraction is stroke volume over that left ventricular end diastolic volume. So kind of how much your blood, your LV is spitting out in one beat over its number at its fullest. So I'm very visual and very practical. So sometimes, I just like to solidify things with examples. So these numbers are not real, but let's say, patient A has a left ventricular end diastolic volume of 30 mils. When their left ventricle contracts, they eject 15 mils out into systemic circulation. Let's say patient B has a left ventricular end diastolic volume of 300 mils. When their left ventricle contracts, they get 150 mils into the body. So in these two examples, right, your patients will both have an EF of 50%, but there's going to be a really, really big difference in the amount of cardiac output and blood that these patients would get out to their bodies, right? So that's why patients, with diastolic heart failure and me, we have the same ejection fraction, but it's all a relative term, right? Because as your space gets smaller, you still have that same percentage.
Perfect. So it really seems that the whole thing can be misleading if you're not really thinking about it. Because again, I've always wondered, like, hey, this person's 55. Like, what if I'm 55? Like, we don't have the same jazz going on. But I think you've really categorized it by, all right, 55% of what? Like,
exactly.
Of what? That's the cool part about that. And again, we don't have flow track and some of the cool fancy tools that you guys may have in a unit to kind of give a real number to this. So I think this is really cool for us to be able to understand what are we actually looking at. So that helps out versus just, it's just contracting a certain way versus it's contracting and doing what. So that's the way I like to think about it. So we really chatted. Now we went back to the Magic School Bus and we had a little break and got us a water bottle and squeezed some in. And sometimes we had something to squeeze and sometimes we just squeezed too lightly. So now we kind of understand the systolic and diastolic in the ejection fraction. Let's transition now. You spoke on it a little bit, but this is actually another thing that we have to kind of pause because we just find all those, but let's talk about the causes of these because I think most people say, well, you just eat pretty bad and that's why you have heart failure. There may be a few other things that lead to that. Can you walk us through what these triggers look like and what are these causes of heart failure?
Yes, for sure. So it's going to differ oftentimes based on what type you have. So when we're thinking about systolic heart failure, again, we're thinking about weakened muscle. So ischemic HF-ref is going to be very, very common. It's going to be about 70% of your patients. And these are patients who have chronic ischemia, CAD. They come in with MI and ACS, and now they literally just have ischemic heart muscle. Those myocytes die, and now they just don't have good squeeze anymore. There's also non-ischemic causes of HF-ref, a little less common, but patients with chronic hypertension and also your infective and myocarditis, all your kind of immune issues. Patients with valvular disease can end up with both HF-ref and HF-pef, and then also AFib, right? So the longer you have AFib, the more structural changes that your heart will undergo, the more likely you'll be to stay in AFib, but that's a whole nother story. But AFib is commonly going to be a cause of these types of heart failure, especially as our patients get older.
Perfect. Again, thinking of it as, I'm always thinking if you slap your muscle a bunch of times, that thing's going to die and it's not going to be able to lift up as much anymore. So I always try to make this as simple as possible. And I really think we did a good job of going back to some of the basics. And I think sometimes we really overestimate our confidence in us actually knowing some of these things. So I'm happy we was able to do that because oftentimes we'll say, I understand this or understand that, but you're just familiar with the words. you haven't looked at it in a while. So even if you've been practicing it for a while, I always want to go back and figure out what's a different way that you can teach it and make sure you truly understand it. So I'm really excited about that. Now, a question that is really, really big for me is how do I get people to stop coming to see me? How do we avoid hospitalization? And we see the logs in the EMR all the time. And again, acute decompensated heart failure readmit in 30 days. We know this is going to be killing our reimbursements. We know hospitalizations are driving outcomes as well. Can you walk us through, again, why does this even matter? Like, what are those other things for us to consider?
Yeah, I think that's a really great question. So first thing to kind of think about is that unfortunately, hospitalization is a pretty bad marker in these patients and signals a bad prognosis. So I kind of think of it kind of like when we're thinking about our COD patients who say, you know, once they have an exacerbation, they never truly return to their baseline. That's kind of how heart failure is. The more you get hospitalized, the worse your heart failure becomes, the more likely you are to be hospitalized. And we all know those 30-day readmits. And so some things to kind of keep in mind when you're talking to your patients about potential triggers for why they came in. Obviously, compliance with GDMT or guideline-directed medical therapy, you know, not having it prescribed to begin with, we see sometimes. High sodium diet. So unfortunately, probably everyone in the ED knows this. The day after Thanksgiving, the day after, you know, Christmas, the holidays, we see these patients come in. And then other types of things. So, you know, let's say they started on a med that they shouldn't. So like diltiazem, it's a negative inotrope. So it might worsen a patient with systolic heart failure's heart function. And then other things like uncontrolled hypertension. So it's important to talk to these patients and really educate them and also get them on top of watching their weights, watching what they eat, and kind of being able to reach out to their primary care provider or their cardiologist before they get too volume overloaded and now they have to come in for IV therapy.
Perfect. That's one of the things that I think we really, really have to do a great job of in the ED and all of acute care is focusing on how to optimize these patients and make sure they don't come. Because again, once they come see us, usually it's pretty bad. And it appears that once they see an ED pharmacist, they never get better, which is horrible to think about. This is a disease state. Every time they see us, they're just never going to get better. But time to talk about all the different types. And I think when we think of heart failure, everyone has this classic textbook image with those 4 different charts in their head. And they say, okay, we're going to talk about, you know, cold versus warm and wet versus dry. And that sounds really good coming off our tongues. Then the patient ends up in front of us and is like, So let's break these patients up and dive a little bit more into these different things based on the different categories from your perspective. How do you define these things in real life?
Yeah, so you're talking about the Forrester plot, which I think hopefully no one has, you know, terrible flashbacks to their cardiology class, but just like you said, it's kind of that classic thing that everyone thinks about. So when we're talking about it, we're kind of really assessing 2 main buckets for these patients. The first really being volume status, and the second being perfusion or cardiac output. So, you know, we're looking at 2 different things. So let's start talking about perfusion. So how much blood that heart is actually able to get out and into the body. So in perfusion, that's when we're thinking about, you know, cold versus warm. So for perfusion, we use a term called cardiac index, which, as you guys know, it's similar to cardiac output, but it's really kind of standardizing it based on a patient's body surface area. So, you know, then it's really easy if you have 2 patients like me versus Dwayne The Rock Johnson in the next room. You don't have to try to calculate cardiac output for an individual patient. You know really quickly their cardiac index. So the cutoff that's typically used where we're saying perfusion is either good or not is 2.2 liters per minute per meter squared. So if it's less than that, we're kind of worried about the perfusion. If it's more than that, we're less worried. So some signs of low perfusion that you're thinking about. So I always think about the whole point of perfusion is to get blood and oxygen to the organs, right? So what organs are we thinking about? Well, one is the brain. So patients can have altered mental status. One of the other ones, which is usually hit first, is the kidneys. So patients will have AKI, they'll have low urine output, decreased urination. We can also see reduced perfusion to the liver. So a little less common, but if they're very severe, we could see acute liver injury. And then other things, right, to assess perfusion. So how do they feel on physical exam? Do they have cool, clammy extremities? Do they have delayed capillary refill, weak pulses? Those are kinds of things we're thinking about when we're thinking about perfusion. The next bucket that we're thinking about is volume status. So in order to assess this, we kind of think about the pulmonary capillary wedge pressure, or PCWP. So as you guys probably know, in order to get this number, they throw a little catheter, a thin flexible little tube with sensors into your vein. They're going to float that to the right side of your heart, through your right atrium, through the right ventricle, through the pulmonary arteries, and then let it sit in one of the branches of the pulmonary artery. So when they put that in there, the end of that catheter has this little inflatable balloon section that they inflate for just a couple of seconds, and it will read that pressure. So that pressure is really telling us a marker of preload, which is really telling us about the amount of volume that enters the right side of the heart. So the Forrester criteria really uses 18 millimeters of mercury as that cutoff. So if you have a wedge pressure greater than 18, you're considered to be volume overloaded or wet. Other signs of volume overload that we classically see, oftentimes, right, you don't need to get a pulmonary capillary wedge pressure for this. You see things like shortness of breath, weight gain, lower extremity edema. From the physician side, they see those lung B lines on the point of care ultrasound. You can also see IVC dilation on the ultrasound, the IVC being non-collapsible. And then some lab things like elevated BNP or NT-proBNP. And then from other diagnostic tests, you can see pulmonary edema on chest x-ray. So patients can really present as a combination of all of these, obviously the worst being cold and wet.
Absolutely. When we see a patient, and I think it's more complicated when a patient just drops in front of you, you're trying to see all the different components of their disease state, because unfortunately, the heart failure is not going to come by itself. It's going to come with a host of other things that it could be. And the one that really pops up quite a bit in my ER is the combination of the differential diagnosis of, is this community acquired pneumonia or is this going to be heart failure? Because you're going to get a chest x-ray and say, oh, there's a bunch of stuff on there. Is it pulmonary edema? What is it? So I think kind of looking at these patients, getting to know a little bit more about them is going to be key. But before we move on to the next big section, what else are you asking your patient right now? Like, what are some real world pearls we can gather some more information before we start transitioning to some of the other things we're going to do?
Yeah. So when you're talking to your patient, you want to know some things that might potentially even guide treatment. So what is their home diuretic dose? That's going to be really important when we're thinking about how we're going to dose these patients with loop diuretics up front. If they know their dry weight, their euvolemic weight, that would be fantastic, even if we get a good estimate of that. And then, prior to discharge, again, talking to them about, can we identify a trigger for why you came in, like we talked about before, and how can we kind of prevent that from happening?
Perfect. So I think we've done a lot of the background components to really dive into the next section. We haven't really talked as much about drugs. What we have talked about is understanding what heart failure is and realizing that this is going to be a pump failure with either impaired fill or squeeze. And then we went into all the different types. And for some of us listening, this may be the first time of us hearing about, HF Mr. EF and HF-Imp EF alongside with our HF-Pef and HF-Ref. Then we really talked about the Magic School Bus. And for all of us that are, millennials and beyond, we actually got to watch the Magic School Bus. So I think now our students may not necessarily, and our learners may not know, maybe your residents don't even know. But we went and talked about how that explains things in EF. And then she really nicely went over to ischemic and hypertensive and other issues. And then the big thing is if a patient is seeing you in the hospital, no matter where you work in the hospital, that's a sentinel event, and that's bad because they may not get better, to get to their best anymore. I think we talked about the Forrester plot and talking about the warm and the warm, the cold and the warm and the wet and the dry, and really making sure we get a ton of history from these patients because there may be some different things that's going on. These patients may end up on some non-invasive ventilation that may prevent them from talking to you as much. So we really want to gather as much data as we possibly can before we start treatment. Okay. Up next, we're going to talk about how to manage these patients. Talk about diuresis. We're going to talk about GDMT controversy, strips, disposition, discharge planning, all of that. Stick around and we'll get to it. All right, Cait, let's jump right back into it. I can only imagine how frustrating that it is when you see certain medications and heart failure get stopped. And I can imagine that GDMT gets held more often than it should, especially when we think we may actually impact blood pressure. So what are the instances where we should actually be holding these medications?
Yeah, I think that's a super important question. And I think the latest guidelines really actually made a point to emphasize how important GDMT is both continuing it during hospitalization and then trying to get it back on board if you stop it prior to discharge. So the guidelines are really, really trying to enforce that pre-existing GDMT should really be continued and optimized even unless truly contraindicated. So if there's, let's talk about like a mild decrease in renal function, asymptomatic reduction in blood pressure, because keep in mind, a lot of these systolic patients, systolic heart failure patients will just have a low baseline blood pressure to begin with. But in those cases, really diuresis, GDMT, none of that should be discontinued. And if we do get to the point where we stop it, it should be reinstituted as soon as possible. So whenever I'm looking at my heart failure patients every single day, I'm thinking about GDMT, and it may not be something that we're going to start today, but every single day I have that conversation with myself and with my learners. What are they on right now? What can we get them on? Should we do it today? Should we wait? But that's always kind of on my radar there. There's plenty of evidence supporting that stopping GDMT during hospitalization is associated with higher rates of post-discharge mortality and readmission. So just like you said, oftentimes it's stopped and then not put on afterwards. So when do we really hold? So truly when we're talking more towards patients with cardiogenic shock. So if they are truly hemodynamically unstable, like systolic blood pressure of less than 90 or of a heart rate less than 50, the guidelines really go as far as saying like the true contraindications for stopping these meds are going to be pretty rare, with one of them supporting like if the patient has cardiogenic shock, of course you should hold it at that point. But really, again, these are medications that I'm constantly thinking that, let's not just rush to stop them right away. And I'm constantly thinking about when can we restart them.
That's great, because one of the things we think about quite a bit is wanting to like stop a beta blocker or wanting to stop something just because, like you want to do those things just because. And in our head, it makes sense initially that to hold all these drugs, but it looks like this may be worse off for the patient, inpatient. And that's the biggest thing. I'm so happy that you work inpatient and outpatient, because a lot of times I hear that's for their, ambulatory care pharmacists to deal with.
Oh, I know. Yes.
If I'm hearing correctly, the way I want to think about this, GDMT is going to be similar to how we do antibiotic stewardship every day. Hey, do we need this? Hey, do we need this? And instead of trying to pull off, we may be putting back on. So it reminds me of some type of reverse stewardship process where you're reinitiating versus taking things off. And I think a lot of people think about, the de-resuscitation phase, which we're going to get into shortly, but I don't think that they're focused on getting these medications back on board. And it appears that it's really, really bad. All right. So we talked a little bit about that. I think the star of the show here is going to be, and I need to get a sound bite to add on here. Anytime I think about loop diuretics, I always have this song in my head, like, loop, there it is.
Oh my God. There it is. Wait, that is amazing. I have never heard that yet.
So I'm always thinking about loop diet. Every time I think of it, it's just for some reason that comes in my head, this old 90s song playing in my head on loop. So let's go ahead and talk about diuresis strategies, because I think that we may not be being as sophisticated as we can. And I know that there's going to be a cardiologist and a nephrologist fighting somewhere. Put it all to the side, guys, while we work on this. So is there a role for routine, like invasive monitoring, or is the physical exam with assistance from lab markers okay to take when it comes to our strategies?
Yeah. So for years, really, we talk about that gold standard for volume overload being that wedge pressure. But interestingly, when you look at the data behind invasive monitoring versus not, there is no data really saying that invasive monitoring can or does improve outcomes. So it can be useful, and that's kind of how it's endorsed in the guidelines. It can be useful to guide management in really carefully selected patients who maybe are still symptomatic despite treatment, and maybe you want a little bit more information about what's actually going on in there. But really, there's no established role for routine use. And, I always say, like, as clinicians, we love our numbers, we love our data, it makes us feel good. But this time, it's not really translated into hard outcomes.
So how do we diurese these patients? Because we talk quite a bit about, some of the markers to look for, some of the physical exam to look for. What dose do we actually put on these patients? Because I think that we may be getting this lost. And if you possibly can, give me an example of an actual PO to IV conversion, because this get lost in the sauce all the time.
Yeah. So I think when we're thinking about diuresis, the gold standard, like you said, is still going to be our IV loop diuretic. So that's been our mainstay for years and years, and probably not going to go anywhere anytime soon. So we continuously see that our IV loops have the most rapid, most effective method of decongestion in these patients. And every patient that comes in should really have a discharge plan that you're discussing about how we're going to adjust diuretics at discharge to, again, hopefully prevent these patients from coming in again. As far as dose and dosing strategy, so it's a big question to ask. What dose do we put these patients on? The interesting thing about loop diuretics is that with chronic use, we really see this development of resistance. So in other words, patients need higher and higher doses in order to achieve that same basic diuretic effect. So because of this phenomenon, it's not going to be a one-size-fits-all approach. As far as what dose we do, this was really investigated in, it's a very landmark cardiology trial. It's the 2011 DOSE trial. This trial looked at two different things. Their first question was, are high dose of IV diuretics better? So they defined that as 2.5 times the home dose given as IV, or should we do low dose, which is just whatever they were on at home as IV? Their second question was, what's better, continuous infusion, or should we just do IV bolus for these patients? So the trial found two different things, obviously. So the first thing they found was that high dose IV diuretics is really what we want to go for. So that 2.5 times the home dose as IV. And I think it's also really important to note that 2.5 times dose of, their home diuretic did not actually even account for bioavailability. So when we're thinking about furosemide, if you're on Lasix 40 milligrams PO at home, at your hospital in that trial, you would really be getting 100 milligrams IV, which really shows that initial high dose upfront should be aggressive. The other thing that they looked at is that continuous versus bolus dosing, and they found that there's really no difference between those two strategies. What I do want to say, though, and I thought was interesting about the trial, is for continuous infusion, they did not do an initial IV bolus. So it kind of makes sense that they might have not found a difference because, starting at a low drip rate, I'm thinking in my brain about, the drug concentrations getting up to that diuretic threshold. It's going to take a long time to get there before they start urinating. So, it's kind of a controversial topic. I personally think that, if we're doing continuous infusion and you give that IV bolus up front, I do actually consider that an escalation of care from just IV bolus. But, for most patients, IV bolus should be really your mainstay in what you're doing first. And then continuous infusion, you can consider, let's say, if your patients are really sensitive to fluid shifts and they get hypotensive with their blood pressure, things like that, where you have to be a little bit more gentle, or we need an escalation of diuretics, then I consider doing continuous infusion.
That's great, because when I read the study and when we're not necessarily seeing these patients long enough to get there, usually what I'll see my team do is say, all right, Jim, let's give 40, let's give 80, let's call cardiology. And that's usually it. They don't even consider sometimes the home dose. And when they do, I usually have someone think about the furosemide, bioavailability and not even consider it and say, well, if they're on 40 at home PO, do I get 40 IV? And then when do I double it? And it's just a host of different things that goes on. So we know that quicker and big doses are associated with better outcomes. But I think the other side of this that probably gets a lot of arguments between the cardiologist and the nephrologist is the adverse reactions. So speaking of these, what are the ones that we should look out for? Because I think some people may not think about a few of these.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.
Perfect.